Hi, my name is Winston Linquister, and I'm a current undergraduate at Duke University. So, to those who may be wondering, the purpose of this podcast is to both fight stigma surrounding mental disability, as well as give a face or voice to those involved in disability studies, a field of study that is quite often unnoticed or unknown to many. Now, mind you, I don't have any real experience with video or audio editing, and this entire podcast is basically amateur. However, I hope either way, these conversations can give to our audience a better understanding of disability studies and those involved in it. So, thanks. I hope you enjoy and have a great Disability Pride Week. Everybody, and welcome to today's episode of the Mad Studies podcast for Disability Pride Week, your podcast for breaking down stigma and bringing the voices of disability studies right to you. I'm your host, Winston Linquister, and today our guest is Guy Weissinger, a PhD student at the University of Pennsylvania School of Nursing with research interests in medical health disparities of people who experience quote-unquote mental illness. So let's get started. Thank you, Guy, for coming on our show with us. How are you doing today?
I'm doing great, and I'm really glad to be here. I think that this is a really interesting idea that you have for, a podcast and for kind of breaking down stereotypes and talking about things. I think that I'm a huge podcast fan, so this is a great avenue for it.
Well, thank you. Thank you so much. So let's just get right to it. So, Guy, for those of our audience who may not be familiar with you or your work, do you mind telling us a little bit about yourself?
Yeah, sure. So I'm kind of a narrative person, so let me roll it back. So I did my undergrad education at Rice University in Houston, Texas. I majored in religious studies and psychology. I then got my master's in counseling psychology from the University of Pennsylvania. And through that entire process, I just had an interest in kind of how both kind of the mind works, but also how people cope with life. That was how I was very much focused on my studies and my work. And I worked for a few years after I finished my master's and got a really big interest in the intersection between, what we label as mental illness, but what I, a lot of the time just think of is just how people's heads work in the world that we live in. And healthcare, this monumental giant system that kind of befuddles us all. And so I ended up entering a BSN to PhD program for training both as a clinical nurse and also as a researcher. And my focus is on kind of poor health outcomes for people who experience mental health problems effectively. So looking at how the way that people experience physical care and how they receive it, but also what are their outcomes are really worse for those people that have, differences in mental health.
If you don't mind expanding on that, what ways are they worse?
Yeah, sure. So, I mean, it's there's a lot of different theories about why, but in general, with the patient populations that I focus on, because how it works for at least for us in our research programs is you choose a population, you choose a setting, and you choose an issue. And so my setting is hospitals, so medical, surgical floors. My population is what kind of when you run the research game, you use the words that everyone else uses. So you generally would say people with serious mental illness or people who have. The idea is that it's people who their mental illness interferes with their ability to deal with everyday life, not just makes it difficult, but has gotten to the point where they're unable to take care of basic necessities. So generally the idea is people with symptoms of psychosis or acute mania and or severe depression. And that what it is that people with these kind of expressions of symptoms, the way that psychology works is it's hard to say that they're a single thing. So generally we think of them as just a set of symptoms. They have pretty much worse outcomes on everything you can think of. I mean, they have, in the hospital setting, they have more rates of infections. They're more likely to be rehospitalized. They have longer stays. They actually have higher rates of mortality and intensive care admissions just during a hospital stay. In outpatient settings, people with these clusters of symptoms have higher rates of stroke, heart disease, kidney disease, and kind of all of this adds up overall to around 20-year shorter life expectancy, which I think is just appalling. And my work with these, with the people that experience this, has always been just trying to help them deal with the really complex world of healthcare, and recognizing that it's a struggle for me to do the things that I need to do to stay healthy. And, it can be a much greater struggle for people who are balancing more balls than I can possibly count.
Definitely, definitely. So, what exactly makes their experience, like, why is their experience so much harder, from what you've seen, and how would you help ease their experience within the mental, or sorry, not within the healthcare system in general?
I think a lot of it is stigma, honestly. I mean, I don't have the hard data to say I can directly show that stigma in this circumstance with this group of people leads to poor health outcomes. We can say it in a lot of populations. It's been pretty consistently shown that having high levels of both self-evaluated stigma and then using kind of measures of stigma like missed care that is standard, but only certain groups aren't receiving it. You kind of can extrapolate that's probably related to stigma around these people, are very related to poor health outcomes. And a lot of it is that, these people, they're very stigmatized in the healthcare world. There was an entire set of literature that's kind of fallen out of favor, thank God, and it was the difficult patient. That was the way that they were kind of conceptualized as people in their, not even as people. They were the difficult patient. They weren't someone who you could work with, someone you could help. They were a problem. And that really is still evident in the way that nurses, doctors, physical therapists, all of these different healthcare workers engage with these patients. And there's a lot of stigma, and then a lot of it kind of, once you're past stigma, there's a difficulty that a lot of people have with recognizing how high of a burden healthcare can be for someone who has nothing else going on. And so for people who struggle with, these mental health symptoms, or who, even if it's not strictly driven by their mental health system or their mental health symptoms, but is maybe driven by the fact that we have a very strict society that says that if you behave in one way, you're okay, and if you behave in another way, you're not okay. There's a lot of the healthcare system. It wants things to be organized and standardized and pretty. It doesn't want things to be individualized and accepting that people might experience something differently or understand something differently. And there's not that willingness to maybe work with people more or work with people differently. And so my goal right now, I'm just a PhD student, is to develop an understanding in the literature. I have my experience as a nurse, but kind of getting it out there into the scientific literature of what are these patients experiencing? What is it like for them to be in the hospital, to have to work with all these people who, in a lot of my experience, don't really treat them very well, and sometimes don't even respect them as humans. So I am hoping that by understanding their experiences, it can be a springboard to understanding how we can deliver more effective care that respects them as people, because I think that's a really big missing piece.
Wow. It sounds almost like a form of objectification. Like they're, as you said, they're not people, they're patients. So I guess
Yeah.
the natural springboard off that is how can we adjust treatment to treat them like they're people and make it more individualized to get rid of that idea of fixing a patient in the most pretty and fastest way possible, instead treating it like to everybody's individual needs.
I mean, I think it's. I wish I could give you a kind of a silver bullet or a thing that we could do that would make this an obtainable goal. But I think a lot of it comes down to talking to people, just sitting down and sharing a conversation and then another conversation and developing relationships of understanding, because people want connection in general and they want to be treated well and respected. And a lot of it is you can figure out what someone needs to overcome their difficulties. In a lot of cases, not every case, things get very complex and there's a lot of issues in the world. But in a lot of ways, you can find out what somebody needs or help them to achieve things themselves just by talking to them, recognizing where they're at. I have a bias here. My background's in counseling, so I want to talk to people and I want to engage with them and find where are their strengths and what are the things that they feel like they need work with. And I've found people, I don't have the data to back it up, but I've had patients who told me, they said, you were the first person who explained to me what was going on. You were the first person who told me why we were doing what we were doing. You were the first person to ask me, what's my house like? Instead of saying, here's the things you need to do when you get home. So I think a big part of it is just asking people to approach patients as people who have different circumstances, who have different ways of thinking, and training them to do that. It's not something that is easy for everybody. Nursing school, medical school, physical therapy school, even social work school at times, they're very intense, and they can make it where you are devoting only a portion of your brain to what's going on in front of you, because you're having to think about all of these other things that you need to be doing. And it can be hard to get back into that moment and to think about this person and what do they need. And other things are just, recognizing that people, you might not be able to have if a person comes in and they have a particular health problem, and the way that we give them discharge instructions is X, and that works for everybody, might not work for them. And we need to recognize that things can be done well in alternative ways. The way that I talk to people is to generally just figure out what do they want and how can we get them there. Most people want to be healthy, so it's a very easy hook. But sometimes people don't, they don't care about that, but they care about attending family events or being able to go to church or something like that. And so most people have a connection, a way that you can help them to think about their goals. And I think that slowing down, talking to them, connecting with them is people, not as room 34 with the heart attack, can actually improve healthcare rather than make it slower or problematic, because you actually know what this person would want and need and how to give them the best care.
Mm-hmm. Definitely. And as you mentioned earlier, your project seems to be tapping directly into that idea of just talking to patients before trying to diagnose them. So,
Yeah.
again, for our audience, do you mind expanding a little bit on that project that you're working on?
Yeah. So my project, and I'm still kind of in the early phases. I haven't actually gotten to the interview portion yet. I've done some pilot interviews actually, but not the ones for the study. But what I'm going to be doing is talking to, for various reasons related to funding, I've chosen to focus on people who have psychotic disorders. So using the kind of the psychological jargon, it would be things like schizophrenia, schizoaffective disorder, mood disorders with psychotic features. But effectively, it's people who experience the world, quote unquote, differently in their senses than other people. My main quibble with that is that I have no idea what anyone around me is experiencing in their symptoms. So it's a little hard to say this person's different and everyone else is the same. But working in the mental health field, there are definitely people who experience things very differently. And there might be contexts where it would be fine and they would be able to function really well, and hopefully society can one day get there. But right now, we have a society that people can't function if they experience and express their experiences differently than other people. And the people that have these different experiences have worse healthcare outcomes by far. And they're seen by nurses, based on the literature and based on talking to nurses, as very difficult to work with. So that's my focus. And I just want to talk to them and say, what is it like to be hospitalized for you? What are you experiencing? A very qualitative methodology of not looking at the numbers, but looking at the person. I'm going to be doing recorded interviews where I just talk to people. You know, I have some interview guides, but it's really about getting their experience of, what is it like to be hospitalized? What is it like to work with all the different kinds of staff? What do you feel are good experiences and bad experiences? What do you think it's important that we as healthcare workers know? What do you think it's important that I know just as an individual who's talking to you? And then taking that information, what we get from the patients, from the people who are in the hospital, and then using that to examine kind of the harder data, the quantitative methodologies. So I'm going to examine trends in this literature, in these interviews, and then see whether we can say, look, you know, these people have these experiences where their nurses, you know, they say their nurses never talk to them. And when we look at it, the nurses don't check in on them. You know, they're not going in. This is a theoretical idea. Their nurses aren't checking in on them. They're not engaging in education and in reassessment and all the things that they should do. And it is associated with poor outcomes. You know, that's the kind of the goal, is to find what it is the patients are experiencing and then validate that in the quantitative world that we as healthcare workers really value. And then be able to say, okay, now that we know that this is a problem, and not just know in this experiential manner, but we can pull up the paper and we can pull up the numbers, then we can say, now we have to change people's behaviors to focus on the needs of the patient again. But you know, I'm maintaining real openness with this. I don't know what people are going to say. It might not be nurses. It might be doctors. It might be sense of being trapped. I know a lot of people express symptom, they're just like, I feel very trapped in the hospital setting, and like I can't be the person I want to be because it's a hospital. So I'm very much just trying to see what they bring to me rather than saying, do you have problems with X? It's just, what's going on?
Definitely. And you mentioned these disparities, basically, and I know you
Mhm.
said that your project is just now starting, but can you give our audience any prominent examples of common disparities between medical healthcare professionals and, say, the desires or more effective, or I don't want to say more effective, just the desires of patients in terms of treatment?
So, um, I could point you to some hard science literature. So there's some that could show that people with a diagnosis, and this is related to stigma and expectations and everything, but people with a diagnosis of schizophrenia in certain settings were less likely to get the guideline treatment surgeries for heart problems. They were more likely to get lower level, less generally seen as effective treatments. So there's that, where it's just like you're just not even offered the best care. Uh, but there's a lot of personal experiences I've had with patients where they told me, and they didn't say, oh, you're the only one who understands me, but they just said, it feels like no one here is willing to talk to me. No one here is willing to listen to me. I know what's going on with my body, and I feel like no one is paying attention to me. And there's just this kind of disparity of experience and of willing to listen, and it's frustrating to me because I think that at the end of the day, I can't say what someone's feeling or thinking, but usually they're willing to tell you if you just ask them. The data on how healthcare workers of all kinds work with patients tends to be a little sparse for various reasons. I can tell you that nurse staffing levels have a huge effect on outcomes, even for various different things. So the number of nurses on the floor, but for a lot of different reasons, I can't tell you whether showing up in the morning and greeting the person and asking them, what are your goals for today and how are we going to get there, is an effective intervention. We have these gaps in literature, and hopefully one day we'll be able to fill them. But for now, you can kind of see that, yeah, it's hard.
So, would you characterize those kind of gaps as just an innate amount of stigma or just a disconnection from doctor to patient? And if
Mhm.
so, how do you bridge those gaps?
I think that it's both. I think that there are, and not just both, like some cases are X and some are Y. I think most cases are both, in that there is honest misconnections of intent and communication, and there is also stigma. Um, I I won't excuse myself from stigma. I won't say that I don't experience it. I mean, I'm a human being, but also I find myself having thoughts of, not wanting to, um, work with certain patients, or having, making assumptions about people that I don't know for a fact. I just assume based on labels that are given me in the chart. And so I think that there's definitely a lot of stigma, but then there's also just people assume that and this is especially common in healthcare, it's common everywhere else too, but people just assume the other person knows what they're talking about. Sometimes medical jargon, but sometimes just you assume that the words that come out of your mouth are the same, are perceived the same by the other person. And it doesn't have to be a mental illness issue or something like that. It can just be that some people aren't good at expressing themselves, and you can have an MD and be a very smart person and have a lot of trouble explaining how to do, post-surgical stretches. You just for some reason the words just aren't connecting with people. So I think it's really both, that people aren't as good of communicators as they think they are, and that there's a lot of stigma and assumptions made around who people are and how they either should be or are, that don't show that people are very unique and very different.
Mm-hmm. So, in also one of your earlier emails, you mentioned your time or your work as a guest lecturer as well. Does that kind of walk into the area of a stigma and fighting against that, or is that a separate entity entirely?
Yeah. So I TA in a class on psychiatric and mental health nursing, and I have been a guest lecturer on a few different things, some completely unrelated, like building leadership skills, and then some on very related topics. So I lecture pretty often on suicide assessment, and part of that is breaking down stigma, both just the stigma of conversation, like things that people don't want to talk about, things that people feel are uncomfortable and seen as shameful to say anything about, and just breaking that down and saying, like, if you can talk about someone's genitalia, you should be able to talk about suicide. I mean, it's just in the healthcare world, some things we broke down the stigma and they're able to be talked about, and some things not. And so part of my lecturing is to address that and to help people to say the words and to ask the questions that they feel uncomfortable around, or feel like, I'm going to say something and this person's going to get mad at me. Or just to recognize that this is something that a lot of people experience, and that it's not a rare thing. It's pretty common. I mean, suicidal ideation is, at some point in their life, most people will have thoughts around wanting to die or wanting to end their life. It doesn't mean that most people will try to end their lives, but it's pretty common at some point in a person's life to have at least vague thoughts, and actually relatively common to move beyond vague thoughts. But so definitely stigma, and then addressing the students. When I lecture, I always say, I don't want to endanger anyone's health here. So if you as a human being feel like you can't have the conversation we're having right now for your own health, your own safety, there is no problems. There will only be no points off. There will be no issues if you have to step out. And I actually say that on pretty much everything I teach, even if it's things that aren't related, because I believe that people come from different experiences. And I might say, oh, I, as a person who's had suicidal ideation, may be, my memories and thoughts might come up based on these conversations, but other people will have different issues that they've experienced in their lives. And I can't just have these warnings for the things that might make me uncomfortable. I need to recognize that, that everybody's different, and there's not a single way to approach it.
So, with this stigma surrounding anxiety, depression, and suicidal thoughts, What can you say about it outside of just a medical setting and just
Yeah.
in general in society? How does that stigma manifest?
Yeah, I mean, so I'm going to just talk about my own experiences for this rather than kind of the research and everything. I have experienced anxiety since I was a very small kid. As a kid, I don't know why, but I had very strong anxiety around buying things. I actually had a really weird habit of I would buy things and then have a panic attack and return them. It was, I was 8 or 9, and I continued to struggle with anxiety throughout my childhood, and once I got into college, it was kind of joined by just feeling of depression, feeling down, unmotivated, and I think a lot of my experiences of stigma, I never had anyone say, and I probably have had people think, but I've never had anyone say your experiences aren't real, your struggle isn't real. But I have had a lot of difficulty talking to people about these experiences. I had a lot of difficulty opening up when I was having problems because I heard how people talked about other people who experienced anxiety and depression. I heard how people, they didn't ever say this to the person, but they talked between themselves about other people. And I knew that even if they didn't say things to my face, that they might have issues with it. And I felt like I had a lot of trouble opening up to other people and saying, I struggle to keep my thoughts under control. You know, such a simple thing to say, but it was a very long time before I was able to tell people that these are things that I struggle with. And I think a big part of that was just I knew that there was a lot of stigma around it. And I knew that even people who to my face would say that they were sympathetic might not actually be. And in especially suicidal thoughts, I think that there's a lot of stigma around because there's a sense of it being weakness, that there's and to a lesser extent, I think anxiety and depression also have this, that it's a moral flaw to experience these thoughts and feelings, that you're somehow a bad person. And I have kind of in my own way addressed it, at least amongst my friends, by talking about it a lot. And I will talk about it in class. I will talk about it to teachers. I will talk about it to coworkers. I don't generally talk about it to bosses. It's just there's levels where, you know, you even if for a person who's relatively open, you're still maybe afraid for your job at times. But I will talk to people and I will address the fact that, you know, I sometimes don't feel in control of my thoughts. I feel they're racing too fast and I can't stop them. I will address the fact that sometimes I have had days where I don't know if I want to have another day. And where I feel like ending my life. And that's helped me a lot, I'm not destroying stigma. It's not gone, but I've just made it to the point where you either have to engage with me on this because I'm going to talk to you about it, or you just don't talk to me, which at that point I think I would be better at. But yeah, I mean, I think stigma kept me from talking about struggles that I was having, and not just these kind of struggles, but a lot of different struggles, because I was afraid other people would judge me. And also kept me from getting help, even if not just professional psychological help, but any kind of help, because I felt like people would blame my any other problem I had on these difficulties that I was having.
Thank you so much for sharing those personal experiences of yours.
Yeah, it's fine.
Um, Now you brought up a lot in those personal experiences, but first one I want to touch on is, um, I guess, how this stigma manifests in careers. Uh,
Mm-hmm.
the difficulties it might be for people who suffer from certain mental illness to disclose to employers, or even accommodations for within a job setting.
Yeah. Um, and I think that, I guess, stigma shows up a lot in careers, and um, for me, as I said, it's a lot of the time showed up that I'm much more uncomfortable talking to my bosses about anything, because part of who I am is a person who experiences mental illness, and um, to report that, there's still a lot of stigma, and so I build a wall. So it's a personal experience, but talking to other people, it's a struggle, because very few careers accommodate any kind of illness, any kind of differences in ability that fluctuate. Um, they don't recognize that people function differently day to day. The way that we have jobs, it doesn't really recognize that. And so most people I know hide any differences, whether they be physical illnesses or mental illnesses, um, from their work. And a lot of the times it leads to difficulties. And but the thing is, I would never tell someone don't do that, because I also recognize that we live in a world where no matter what the law says, I know people who've been fired or let go for differences in functioning that fluctuated, they had a diagnosis of a mental illness that did not preclude them from doing their job, but did have a lot of stigma to it. And so, yes, in the ideal world, I would tell people, like, be open, be upfront, be who you are. But living in a world where bad things happen, I would say people need to kind of gauge the room, think about what's going on, and and think about jobs that, and this is something you don't always control what job you're going to get. The world is difficult, but thinking about jobs and careers that can accommodate maybe the experiences. There's some jobs you can work from home, but very few nurses get to work from home. You have to be kind of in the hospital, and it's hard to have a day where you're not there when you have 6 patients, where you're kind of mentally checking out. But I think it's hard to have a career, and weirdly, I think that some careers that we think of as being very high-powered and very prestigious are actually more accommodating to that fact. So academia tends to be more accommodating. It can be very hard on people, and it can break people, but academics tend to have a lot more flexible time. And I know a lot of academics who struggled with mental illness, but because of the flexibility of their work, they're able to accommodate it. So thinking about that, but in general, it's all about reading what's going on and trying to figure out, is this a situation where me being open is beneficial, or me being open might get me unemployed? And I wish that wasn't the world that we lived in, but it really is.
It's truly sad that that's what we have to live with. But I guess what would you say to members of our audience who do have to deal with that kind of stigma? For someone who, as it sounds like, has at least come to terms with it or overcame it, if you don't mind me saying, what would you say to members of our audience who may be struggling with that right now?
Yeah, I mean, I would. There's nothing wrong with people who feel like they have overcome, but I would not say that I have. And I'm not like correcting you. I'm just saying like it's definitely something that I still work with. I would say if you're experiencing a lot of stigma, is find people that you can talk to. And yeah, it's great to have a great listening therapist who really gets you, but it's better to have friends. For overcoming stigma and for dealing with the world, having a therapist is fantastic, but having friends is really important. For me, having people that accept my differences has been the world. And that doesn't mean that they don't get frustrated with me. That doesn't mean that they don't find some of the things that I do annoying or difficult, but it means that they accept that I am a person and that my experiences are valid, and that that these things that I struggle with are real, and my struggles are real. And it's, finding community has been really powerful for me. I mean, I'm 29 years old and I live with 2 roommates. Yes, for financial reasons, because I'm a grad student and we get paid not very much, but also because these are the 2 people that just always have recognized me as a person and all of my struggles as valid and my experiences as real. And having that sense of community has been something that's gotten me through so much more than having a therapist, even a really great therapist. And that's something that, my friends who have physical differences, especially ones that are invisible, have felt and expressed to me the same, is that, having a doctor that understands you and a treatment regimen that helps is great, but having people who recognize that sometimes you're not going to be at your best and don't care is much more valuable.
Definitely. Thank you so much for sharing about that.
Yeah.
So, unfortunately, we're getting close to running out of time, so we're getting to like the final battery of questions. But
Yeah, that's fine.
before, sorry, before we run out of time, can you give any commentary on current methods for researching mental health and neuroscience, and also any commentary, because this is a podcast kind of centered towards mad studies, your experience or knowledge with the mad studies movement?
Yeah. So my, just really quick, my kind of thing with navigating mental health research is that I'm not sure if any of these labels are real. Not that I'm not saying people's experiences aren't real, but I don't know if any of these labels are descriptive of, whether one label actually is describing 40 different things or 40 labels are actually describing one thing expressed differently. And I hope that we figure that out. But I'm also like working in a world where those are the labels that we get. And so that's my thing, is like, I use the words that people have and that we're using. But if new words come along, I'm fine grabbing onto those, because I want people who struggle to have support. So that's my kind of, with mental health research, it's like labels, not really sure I believe in them, but I gotta use what's out there right now because I'm working in a system that uses them. And neuroscience research, I think, is really interesting. And there's some people at our university that do really interesting neuroscience, behavioral, and mental health research. It's not something I do, mostly because it's generally pretty expensive. Running an MRI machine is a few $1,000,000, so it's a little outside of my purview. But I think it's a really interesting way to think about problems and to think about what's going on with people. But I also think that you can fall into a trap of boiling down people into structures of the brain, into saying your experience is here and therefore it's not real, or it's just a thing right here. So I think we should run down that path and find as much out as we can, but still recognize that people are people, and that you can't boil down the entirety of a human being. And, you know, even if we can say your experience of, you know, changed sensation comes to here, what you sense is filtered through the rest of your brain. It's filtered through culture. It's filtered through all of these different things. And so saying something is a point or a moment or a brainwave, I think can be difficult when people are so complex. So I think there's tons to discover, and there's things that we need to learn there. So I think that we need to do it, but with that voice in our head that continues to remind us, like, we're working with people, not structures in the brain or brainwaves. And for MAD studies, I'm kind of a novice to the idea. I've read a few articles. I think it's really interesting because I am a big believer in, yes, using the things that we've been given and trying to get more knowledge, but also being critical of systems and structures and saying, why do we do this? Or why do we think about this in this way? And I think that MAD studies, you know, it's even sometimes difficult for me to say the word mad because of all of the negative connotations. And I know that, you know, some people like it and some people don't. But I think it's a way to say we have an entire system of understanding people that we're not addressing critically, that we're not thinking about, you know, we're saying you can't do X or you experience Y, but we're not addressing critically the entire systems that contribute to and define differences in humanity. And I think that this is a really profound step in saying, why are even these criteria used to say a person is normal versus abnormal, or a person is able versus disabled, or, you know, whatever criteria you use? So I think it's a really interesting way to approach it, and I'm a big fan of pushing back, because even if things don't change, I think in a single moment, you push back the idea that this is how it is rather than this is what we have.
Mm-hmm. All right, thank you so much. So, just final question. Are there any final thoughts you'd like to share to the audience? Anything that you'd like to say that we haven't covered yet?
Yeah, I would say, real quick, I've probably said something that I used the wrong word or phrase. I struggle with language all the time in terms of, like, using language that's appropriate. And, I'll say it's better to have conversations and mess up than to not have conversations at all. But if there's any issues that people feel about my language, I'm also open to getting that feedback. So, and then, for people who experience differences in mental processes, life can be really hard. We have structures in place in our society that say that life should be certain ways, and whether it's because of social problems, whether it's because of kind of mental health or cognitive processes or whatever you want to think of it as, we don't always live up to these structures, and I don't necessarily think we always should, but it can be a real struggle. And I just want to say that it's okay to feel like your brain isn't always working how you want it to work, and that you can still do amazing things and, do whatever you want to do. You have to, just recognize that these differences don't define you.
Mm-hmm. Okay. All right. That's perfect. Thank you so much. All right, everybody. Oh, sorry, I'm getting a little sick. Uh, all right, everybody. Thank you so much. That was Guy Weissinger, and I hope everybody has a good evening.
Thank you.